Hello, and thank you for tuning in, as it were. This video clip is to give a foundation for looking at and discussing antipsychotics. Starting with big picture stuff, and starting that with a focus on receptors. Anything that blocks dopamine receptors in the mesolimbic system will have efficacy as an antipsychotic. Hence the dopamine hypothesis that psychosis is due to a relative or absolute overactivity of dopamine. Okay, first big thing. Second big thing is typicals and atypicals, or first generation and second generation. Typicality arises from the observation that the older antipsychotics, or first generation antipsychotics developed in the 50s and 60s, typically produce extrapyramidal side effects, whereas the newer generation or second generation antipsychotics produced in the 90s and the noughties did not typically produce extrapyramidal side effects. That story is a little bit superficial and it simplifies things, but it's very helpful. It has usefulness and allows us to have a common language about what type of medication we're looking at and what type of side effects they have or are less likely to have. So dopamine hypothesis, and then typicality, atypicality, first generation, second generation. As a sidebar to typicality, atypicals, typicals, there is no evidence that atypical antipsychotics are better at being antipsychotics than typical or older antipsychotics, except for clozapine, which is, for all intents and purposes, in a category of its own, and which I will deal with in a separate video. There is considerable evidence that clozapine is head and shoulders above everything else. For completeness, I should add that there are signals that olanzapine is somewhat better than everything else. But outside of those two considerations, there is no proof that second generation antipsychotics or atypical antipsychotics are better at being antipsychotics. However, they are better at avoiding extrapyramidal side effects. Okay, so indications. Well, antipsychotics are indicated for the treatment of psychosis, classically in schizophrenia, but also in bipolar disorder. They do have other indications and other usefulnesses as well. Second generation antipsychotics can be used as mood stabilizers for bipolar affective disorder. And second generation antipsychotics, some of them have efficacy for augmenting antidepressants in treatment resistant unipolar depression. If they have sedating properties, usually conferred by H1 activity, then they have utility for anxiolysis and for hypnosis, but that will come with a price. And finally, some of the second generation antipsychotics have efficacy demonstrated for severe personality disorder of the borderline subtype. So, that's their indications. Effects, well, they're effective as antipsychotics and for other indications as covered, but I should also point out that although antipsychotics are effective for psychosis, they are not as effective for the so-called negative symptoms of schizophrenia. The withdrawal, apathy, lack of drive, lack of volition, the hollowing out of the personality. Second generation antipsychotics or atypicals are certainly better for negative symptoms than typicals or first generation, but neither of them are particularly brilliant, although second generations are somewhat better. Side effects. I'm not going to start with the more common side effects. Instead, I'm going to start with the less common side effects, but where it's absolutely vital that you think of them and spot them as quickly as possible. And the first one, of course, is neuroleptic malignant syndrome, or NMS. Fever, rigidity, clouded consciousness, autonomic instability. It is a medical emergency. It's crucial that you spot it as quickly as possible. Second side effect that's a bit unusual but crucial to spot it is tardive dyskinesia. Tardive dyskinesia is thought to be due to the dopamine receptors being chronically starved of dopamine stimulation, then becoming super sensitive to dopamine. So it's associated with chronic administration of antipsychotics, and it results in choreiform abnormal movements, usually of the peripheries, but if you're really unlucky, it can affect the trunk. Problem with it is when you've got it, it's too late to do anything much about it. Trick is to avoid it, and we know that atypicals are less likely to produce tardive dyskinesia than typicals. Another one that's not particularly common but important to look for it sometimes or spot it if it's there is hyperprolactinemia. It's common with the second generation antipsychotics ending in the letters DONE, risperidone and paliperidone. Hyperprolactinemia in time is associated with an increased risk of breast cancer. There are signals that there's an association there, but also with osteoporosis. Patients will sometimes describe symptoms consistent with hyperprolactinemia, but it is sometimes cloaked, and patients will not complain of it, and you'll only find it's happening if you check their prolactin level. Then, coming to the more common side effect, extrapyramidal side effects. Antipsychotics work by blocking dopamine in the mesolimbic system, but of course dopamine has agency as a neurotransmitter in other parts of the brain. And with so much of psychopharmacology, it is a little bit like trying to change the spark plugs in a car through the exhaust pipe. You're going to scratch something else along the way. And extrapyramidal side effects are due to the dopamine blockade in the extrapyramidal tract, which is responsible for motor control. So you get your Parkinsonian type side effects, and you also get your akathisia side effects. Next, I want to mention another common side effect, particularly with atypicals, which is metabolic side effects. Weight gain, dyslipidemia, hypertension, insulin resistance. Some of the insulin resistance will be conferred by the weight gain, but some of it will be independent of the weight gain. Quite common with some of the second generation antipsychotics. And I think that's the side effects that I wanted to cover, mentioned for the moment. Looking at receptors, as I emphasized at the start, the dopamine hypothesis, the blocking of the dopamine receptors. The side effect profile of the drug will depend on what receptors the antipsychotic blocks and how strong the affinity. The affinity for dopamine blockade is inversely proportional to the dose. Haloperidol has a very strong affinity for D2 receptors, and the typical daily dose is between 10 and 15 milligrams. Chlorpromazine has much lower affinity for dopamine receptors, and the typical dose is somewhere between 400 and 1000 milligrams per day. Some antipsychotics are very, very selective. Haloperidol, for instance, hits D2 receptors, so you don't need much haloperidol to produce antipsychotic effectiveness, but it also is more likely to produce extrapyramidal side effects. As an example, from the other side of the equation then is quetiapine, which has effects at D1, D2, D3, 5-hydroxytryptamine, noradrenaline, and histamine receptors. When talking about receptors in detail, this is the point at which to explain the difference between typicals and atypicals at receptor levels. For the typicals, or the first generation of antipsychotics, the focus was very much on dopamine. However, in the 90s, it was realized that if you also had effects at the 5-hydroxytryptamine receptors, that seemed to confer atypicality. And the balance between the dopamine and the 5-hydroxytryptamine receptors seems to be crucial to that. And all the atypicals have effect at the 5-hydroxytryptamine receptors. Moving on then to more practical points. You've got lots of different antipsychotics. You can group them into typicals and atypicals, but even within that there is a lot of heterogeneity. Side effect profiles differ, not just between the two arbitrary groups of typicals and atypicals, but even within those groups. There are some ways of short-cutting it to try to get a grasp on it. These are crude but effective techniques for trying to remember what side effects go with what medication. The antipsychotics ending in the letters PINE are more likely to produce sedation and more likely to produce weight gain and less likely to produce Parkinsonian side effect. That is your clozapines, your olanzapines, and your quetiapines. So anything ending with pine will give you sedation, will give you weight gain, and is much less likely to give you extrapyramidal side effects. With the atypicals, anything ending in DONE is not quite as likely to produce metabolic side effects, is more likely to produce Parkinsonian side effects, and is more likely to produce hyperprolactinemia. These are your risperidones and your paliperidones. Then you've got your zoles, Z-O-L-E, and at the moment effectively the only one in this group is your aripiprazole. This is almost in a subcategory of its own right because it's also a partial agonist at dopamine receptors and moreover a partial agonist at 5-hydroxytryptamine receptors. Aripiprazole is pretty much neutral for sedation and weight gain. It is pretty similar to the pines for extrapyramidal side effects, but it can be difficult to tolerate. It can produce agitation on initiation, which patients find difficult and is difficult to manage. Looking then at Monitoring, well, monitor for side effects, check for Parkinsonian type side effects, cogwheel rigidity, check for akathisia. Also look at weight, consider doing a baseline weight, look at blood pressure, particularly with the atypicals, prolactin, particularly with the dones, and potentially ECGs. Finally, a mention for depots. The compliance of Homo sapiens with medication is a bit of a vexation when it comes to the practice of medicine. We know that humans are very poor at taking medications. This is even when they have a high degree of investment in taking the medication. We know, for instance, that compliance with the oral contraceptive pill is rarely 100%. It's even more of an issue than when the patient has limited or no insight or is ambivalent about taking the medication. We figure that at least half the antipsychotics that we prescribe go into landfill. They don't go into our patients, but we don't know which half of that equation a particular specific patient fits into, and we're pretty poor at guessing. Related to that, and in general, there's also a problem with chronic prescriptions. We know how many patients fall off taking their antibiotics when you're looking at a 7 or a 10-day course, but when you're looking at a chronic prescription, it's even more of a difficulty. Depots are very helpful and very useful. Depots in and of themselves do not prevent non-compliance because people need to turn up for the depot. But what they do is prevent covert non-compliance. If somebody doesn't take their pills, I may never know about it. But if somebody doesn't turn up for their depot, I will know about it when the depot clinic shuts down for that day. And that is very, very helpful information in certain common circumstances. Selling depots to patients is another matter entirely. Okay. Well, thank you very much for your attention. We will look at antipsychotics in a bit more detail in supervision sessions, face-to-face. Look at your experience, look at any questions you have, and clozapine, because it's so different from everything else with so many complications and so many considerations, I will deal with separately. Thank you.